essentially, it is breaking the skin in a foot that is anywhere below the level of an ankle in someone with diabetes. People with diabetes tend to have three major reasons why they can get diabetic foot ulcers. Of course, there are many more, but fundamentally nerve damage, which makes the foot insensitive. There can be circulation problems, which can drive less blood to the foot, leading to the skin breaking off. And of course, change to the foot shape, which causes pressure points. And then when these pressure points are exposed to an environment, either barefoot walking or within shoes that are too tight or not properly accommodated, you can get a break in your skin, and this is called a foot ulcer. And a foot ulcer is quite a serious diagnosis because they're very challenging to treat, very difficult to heal. And if you look at the data from United Kingdom, 1 in 2 of these ulcers struggle to heal within the 12-week period. It's a break in the skin, and it could be anywhere in the foot. It could be on the sole of the foot, it could be on the sides of the foot, and it also could be on top of the foot. We call the top the dorsum. Anywhere could lead to a skin break, which we call a diabetic foot ulcer. Now, the reason that drives the foot ulcer and understanding that is very important, because your treatment that you receive depends on it. Ulceration over the tips of the toes, especially with evidence of skin damage and early gangrene, indicates that there is a circulation problem, and this needs to be addressed through a good vascular team immediately. But ulcers on the sole of the foot are often related to nerve damage and pressure over bony deformities, and these require adaptation and protection within either a special shoe that can take the pressure off the ulcer, or even a total contact cast, a cast which looks like what you get applied if you have broken your foot, because that will take the pressure away from the ulcer. Either way, making sure we got to the root driver of the ulcer is very important. The other important aspect is making sure there is no infection. And infection is very common in diabetic foot ulcers. And often they say that infection in diabetic foot are probably the single most common cause for losing toes or even the leg. So we take infection very seriously. And of course, you are attached to the foot, so looking at the individual, making sure the diabetes control is good, making sure the heart, the kidneys and the liver are all working fine, are all part of that, because ultimately what happens to the foot and how you heal the foot ulcer isn't only about the foot, it's about the individual. Often you go and see your GP and you get referred into a foot clinic here in the United Kingdom. There are multiple specialist diabetic foot clinics all over the country, and you can get referred to one of them. The standard of care is that you're seen within 24 hours of you alerting that to your primary care team. Of course, that's sometimes very difficult, but the sooner we see you, the easier it is for us to treat you and treat the ulcer. And the treatment, as I mentioned earlier, depends on what is driving the ulcer. So if there's a big circulation problem, and we will look for a circulation problem in everybody with foot ulcers, and if there is a circulation problem, we work together with our vascular colleagues, our vascular surgery colleagues, to decide whether or not the problem is extensive enough to require a procedure to put more blood down into the foot. If it's predominantly related to nerve damage and pressures, but with good circulation, you may not need that procedure. What you will need is making sure we have protected the foot and sort of put you down on the path towards healing. There is no perfect dressing, and please don't get worked up in one dressing or the other. It's all about getting the right dressing for the wound. If the wound is too dry, we would recommend a dressing that provides some moisture, and if the wound is too wet, we would need a dressing that takes away some of that moisture. All in all, managing a diabetic foot requires what we call a multidisciplinary approach. There is no one person who can treat it. You need a team that has got podiatrists, and these are specialists who have an interest in looking after and managing foot problems. You need physicians such as me. You need surgeons, primarily vascular surgeons and an orthopedic surgeon, but increasingly for big ulcers, we often rely on the expertise of our plastic surgery colleagues. We often work together. No, we always work together, and this has shown to be very helpful in A, healing the ulcer, and B, preventing amputation. It's works of such multidisciplinary team that has led to a great improvement in amputation rates all over the world. And here at London Bridge, we also have a team with world-beating experience who is able to deliver that kind of superlative care that you would require. Do let us know or contact me, and I'll be happy to advise on the next best way to proceed with your inquiries.